webinar this morning. We're delighted to welcome our guy Tsafnat, who's joining us live from Australia. So we appreciate his time zone flexibility to be with us in this window of synchronicity between, well, not quite synchronicity, but just about convenience between Australia and UK. So that's very kind of you, Guy. Great of you to join us. Guy is a well-known expert in the field of AI. I've known him over some years through the computable biomedical knowledge work. So I'm just going to give a very brief introduction and then I'll hand over to Guy for the main presentation. So for the purposes of the recording, could I just ask that people switch off their cameras and make sure that you stay on mute. There will be plenty of opportunity for questions after the presentation. But as we'll be posting the recording, it's easier if we have people with cameras off during the presentation itself. So thank you for that. So a few words of introduction before we get into the main presentation. So Guy's theme, as you know, is AI interactions, key challenges in its widespread use in healthcare. And Guy is a senior research fellow at the Centre for Health Informatics at Macquarie University in Sydney, Australia. So just a very brief introduction about AI and CBK, which is the lesser known of the two acronyms, clearly, computable biomedical knowledge. And if you don't know, I'm Philip Scott. I'm the chair of BCS Health and Care, and my day job is at the University of Wales, Trinity St David. So AI is one of these bucket sort of terms, isn't it? That means lots of things to lots of people. It tends very often these days, particularly in the media, when people say AI, they usually mean some sort of machine learning, of which there are various kinds, and they very often mean deep learning. But of course, it all started with rule-based artificial intelligence, and we still have that with encoded human expertise. And of course, we also see computational behavior perceived as intelligent in things like natural language, especially with large language models, and in various kinds of automation. So in healthcare, we see that in various rule-based things like risk calculators, triage algorithms, alerts, and so on. We see automation with things like transcription, autonomous devices like pumps and so on. And in NLP, very commonly seen now in voice to text both ways, text to symbols both ways, and things like chatbots, and machine learning in models to support prognostics, profiling, image analysis, and recommendations. So a very broad range of things that get called AI. So CBK, computable biomedical knowledge, really covers very much the same field from a different perspective. So the QR code at the top there links you to the BCS page about CBK, which links back to the University of Michigan hosted page on the topic. So all of those various sub-elements of AI also relate to CBK. But the CBK picture thinks about the broader elements of this as well. So things like the FAIR principles, findable, accessible, interoperable, reusable, which is, it started life in data, but we need to extend its use to knowledge. And we also, of course, need to think about standards, about trust in these knowledge assets, and the broader ecosystem within which they operate. So that's very much a whistle-stop tour, and that's all it was intended to be, just to maybe plant some thoughts about the range of fields and methods and technologies in which these issues arise. So I'd now like to hand you over straight away to Guy to present on AI interaction. So thank you again, Guy, for joining us today.
Great, thank you, Phil. Pleasure to be here. I want to start as I share this initially with a minor correction. I was with, so I'm still affiliated with the University of Macquarie University and the Center for Health Informatics, but I am actually a recovering academic now, and I have taken my lab at the university and turned it into a company, and that company is called Evidently, and I will be presenting some of the work we're doing, although the bulk of this work, this presentation is actually academic. So with that, AI interactions. So let's start with the fact that AI has been unleashed on the world in the last year or so more than it has before, but AI is 70 years old. And this is just the next phase in its evolution, although it seems to be accelerating. I'm not 100% sure that is actually correct from a technology point of view, but certainly from a societal point of view, it is. Before we start, I want to ask you a couple of questions. Let's see if we can agree on this. Should AI be used routinely in every aspect of medical practice? And before you answer, it's too late. It doesn't matter. It's already used in every aspect of medical practice, and it doesn't matter if it should or should not. It already is. Let's try a different question. Should it be regulated? Again, that's irrelevant. It is used and it is not regulated, or it is partially regulated, or is regulated as part of some other scheme. It doesn't really matter. It is used, and that's all that really matters. Is it ethical? I don't even care. It's completely academic. The practical value of AI has proven itself enough that it is in practice, and the ethical value, we can ask about it, but nothing's going to be done about it. How about how do we prepare for the inevitable deluge of AI? Well, that's actually something I can answer. We can start to talk about because it is to do with what we do rather than what AI does or other people do. So that's what I want to talk to you about today, is to say a lot of AI is coming, and what can and should we be doing about it? So let's look first at an analogy from chemistry, and I'm talking about, or even biochemistry, I'm talking about drugs. So let's look at an analogy. And first, let's look at this, examine this. Is this a good analogy? So both drugs and AI are trialed in very controlled environments. They're both subject to bias and conflict of interest. They're tested on single, as part of being controlled environments, single morbidities, and both can suffer from adverse events, and or they're measured for both adverse events and efficacy, or safety and efficacy. Most of the safety and adverse events are discovered after the fact. And one other point that's not on here is that both of these fields are actually used by almost all of us, but are really understood by only a handful. Only a handful of people really understand how drugs work, or not all of them, even though they understand only partially. And the same with AI, only a handful of people really understand how AI works, and even them only have partial knowledge. So let's look at a more specific example. Two drugs, methotrexate and probenecid. One is used to treat cancers and autoimmune diseases. It works by killing certain cells. Probenecid is used to treat gout and other uric acid disorder. It removes uric acid from the kidney. Two independently developed unrelated drugs. Two drugs cannot, in fact, be more different from each other here. There's they use two different biological pathways. They treat independently occurring conditions. In other words, they're not normally used together. It's random whether they're used together or not, because they treat unrelated biological system, and yet somehow they do interact. How do we? Not only do they interact, it's quite severely. So if you take both, you can get toxicity from one and reduced efficacy from the other. And how that works is that methotrexate, while it attacks certain cells, it is cleared from the body through the kidneys. And when you use probenecid, it removes uric acid, which makes the kidneys less efficient, which means you could get toxicity with too much methotrexate and not enough uric acid removed from the kidneys because it becomes harder to remove the acid. And so, of course, they interact, right? It's obvious that they interact, and yet nobody has foreseen it. In fact, most of the drug interactions have not been foreseen before. They're only being discovered in hindsight. But when they're in hindsight, they all make perfect sense. And we can look at them and kind of bang our heads and say, how did we not see it in advance? But it's always like that, right? That's always the story. So going back to AI, right now, there is a large number of AIs already in the market, and this is a growing market. So this is, I'll notice this is in 2022. This is before the unleashing of ChatGPT and the recent spate of LLMs. This market was growing at 11% year over year. But today, this is likely to be much, much higher. We just don't have the numbers yet. Let's see where we are today. Here are all the different AIs and application, different decision support systems and so on that are available in Cerner right now. Actually, this is last year. Probably a few more now. This is a large number, but remember, Cerner is only the second largest, which means that for Epic, this number is probably a lot bigger. So with all these, and imagining that there'll be hundreds more, how do we prepare? Okay, going back to the analogy. We've got two drugs and they interact. There's one interaction here. If we take 3 drugs, the chances of discovering this interaction by chance is now 1/4. Why is it 1/4? Because now there are 4 interactions. There's an interaction between any 2 drugs, but also one interaction for all 3 together. So it's much harder. It means we need a much bigger population. We need a lot more people taking the same 3 drugs, which is going to be less likely to happen. And I want you to think, if this is 3 drugs, what happens when you have 5 or more drugs? It does happen that people are put on that many drugs at the same time, but we don't know what those interactions are at all. We have no way of knowing because the combinatoric possibilities are just too high. Even if we had the medical records of all 8 billion people on the planet, we wouldn't have enough statistical power to really find a pattern. Now, instead of drugs, let's go back to AI. So we've got 5 different systems that have been developed by different vendors, tested for different purposes under different assumptions, and all of them are used in the same healthcare system at the same time. Some of these could be AIs for managing resources, or they could be AIs for helping patients manage themselves. There could be clinical decision support systems. There could be a number of applications, even ones we can't tell today, that somebody will invent in the future. If we don't look at the possibility of AI interaction, and we're not prepared, the implications we can have are quite severe. There's going to be decision errors, waste, prolonged waiting. Let's look at an example. If we have one AI that optimizes resources in a hospital, sends the physiotherapist home early because there were because of underuse. Now we have a patient, there's another AI that recommends physiotherapy for. That patient is now required to wait till the morning or miss out on their physiotherapy session simply because those 2 AIs did not interact with each other properly. They interacted only indirectly and unintentionally. So I want to give you an example of something we do at Evidently that is an example of the opposite scenario of that. So here we've got a representation of a large neural network which is a kind of AI that is used popularly. But the advantage of this sort of AI, it can be very general and could be, it scales very well. And you can use it to solve lots of different problems at the same time, even problems you don't know are solvable. But for us, we're looking at characterizing or understanding clinical data the way it is found in real-world data, the way it's collected for primary use, of trying to make sense of it. This sort of structure is not very good because while it can identify many things, it can't identify everything, and precision is very low. So what we've done is we've built another AI that takes this neural network and breaks it down. It segments the data and builds a specific AI for each segment of the data. And then it does that again and again until we get very tiny segments of data, and we apply an AI to each single one of them. And so we've got very specialized AI with very high precision. How high? 6 to 20 times more precise than subject matter experts can do the same task. So this example is how AIs could be actually coordinated, and when they coordinate, they can actually work synergistically. To manage this many AIs, it could be hundreds of these for a particular customer, sometimes close to 1,000. This is a human being cannot manage that many AI, and so we've got another AI on top of this that controls them, generates them, trains them, runs them, and makes sure that they're coordinated. Also resolves conflicts if those are found. So going back to the example, if these AIs that were independent could somehow coordinate themselves without even the vendors needing to do too much other than comply with certain standards, then we could have these AI teams that are actually coordinated. And maybe one AI can say, I'm about to send a patient to physiotherapy. Maybe you want to not send the physiotherapist home yet, and create better use of resources rather than creating all these unintended consequences. So what do these AI need to be able to do that? The short answer is knowledge. And when I say knowledge, of course, it needs to be computable knowledge. And if it's computable knowledge and it's biomedical, of course, we're thinking of MCBK. The opportunity for MCBK is to be that standard that these AIs can comply with and become coordinated and synergistic. So let's remember also that we're not removing the people from this equation. These AI also need to work with people who need to verify, who need to consult, need to work with that team. And so we're looking really at a team that is some AI from different vendors, some different specialists and patients and other clinicians, other factors around the healthcare system that all need to work together. So for that purpose, we've created a website called the Evidence Hub that is, I will show it to you now, but this is an embodiment of that idea of a place for AIs to interact. And I'll show you, I'm only going to show you that aspect of the site. There's more information in the citation link below. So the Evidence Hub holds what we call knowledge objects. These are computable, and they're all open source on the Evidence Hub, but each knowledge object consists of these 4 things. There's a MIME type. The MIME type is listed here on the right, a few examples of types. This defines what kind of object it is, what sort of knowledge it holds. And so different applications can register to handle those kind of objects. And I'll get to that in a minute. But when I say applications, of course, this could be AI, could be interacting with that in real time. All of this is through an API, and it's all free. So metadata includes things like keywords, URLs, all kinds of other elements you can put to make this fair, as Phil mentioned, findable, accessible, interoperable, and reusable. So anything you need there. It also includes a human readable description that bring the human into it as well. There are owners and contributors and version control. Also relationship with other knowledge objects. So one knowledge object could include another knowledge object in it or use another knowledge object in it. Or one could be a branch from another one, and so on. So there could be other kinds of relationships between them. In terms of the computable part, well, that's source code. So here is an example. In this example, it's a bit of Python code, but really the Evidence Hub does not look inside there. It just shows it, but it's really up to the handling application to determine how to treat that computable part. And this is where the MIME type is there to help them identify that this is an object that indeed they can understand. Also, bringing the humans in is discussion. Of course, this knowledge needs to be meaningful. And for that, we need to have a discussion. So discussion can also occur on the same side. The discussion is verified, which means we check it for viruses, we check it for spam, but then it also is moderated by the owner of the object. So the owner of the object might agree or disagree with the contribution, might refuse a contribution. The aim of what we encourage them to do is to actually accept contributions, even if they're on topic, then keep the discussion going. Explain
this meeting
why
is being recorded.
If it's off topic, explain why it's off topic. Okay. Somebody's not. How about now? Okay, that's better. Okay, so the comment is published once, and then the discussion can continue once the author agrees. If you have an unresponding, not, I don't know, hard to get along with owner of an object, you still want to keep the conversation going, you can simply branch this. You can create a copy of this object, any object, it's open source, you create a copy of it, and you start managing that copy. You can just, it's best if you explain why you created this object, this copy, how is it different from the original. But the sort of thing that you might expect to see here is that a knowledge object created for, let's say, a GP system might be different from a knowledge object created for a specialist system working in an acute environment where there's different kinds of tests are available, different kind of equipment is available, for example. The computable, Zoom is misbehaving here a little bit, but the computable part of it is all done through a RESTful API. For those, again, it's a technical term, but it means a language agnostic API that anybody on the internet can use. So this is where applications and AI can self-register themselves with the Evidence Hub. They register themselves. They're called a handler, and there are 3 different kinds of handlers: those that can visualize an object, those that can let you manipulate that object, create new versions of it, and also executors, that's because executioners was taken. But executors are able to actually use that object in their decision making or in their in the application and so on. So again, this is free, and you're encouraged to register your applications. And if you can make use of it, then by all means, please do. Objects on just a little bit about safety, I guess, and review and quality. Objects are private until they're published. This is to allow authors to have half-baked work before it is published, until they're ready for it to be published. So they're published, and remember, private. After that, everybody is welcome to review. So we're moving away from the peer review model where there's 2 or 3 reviewers that are looking at the object when it's published, and if they are okay with it, then the object is published forever. That's not how we do it. The object is published forever, so every version is forever, but and is immutable once it's published. But everybody can review the next version and the next version, and those versions can have their own discussions, and that discussion is the review process. There you can also leave, so apart from leaving comments, you can also branch the object, but then you can also merge it back, and you ask the owner to accept your changes by merging them back into their object. I mentioned anti-spam, but then there's the feature that I'm most excited about, which are the trusted badge awarders. These badges are, the awarders are able to assign a badge to a particular version of a particular object, and that badge contains their name or institutional name, and it can have a link to another resource anywhere on the internet. So the intention here is that, for example, if you are publishing a paper about an object and you want to link it to the journal that you published this in, can put a badge on this object, and that badge can link to the paper about that object, and vice versa. That paper can link from their website to this object. I myself am a father, which made me eligible for telling dad jokes. And so, of course, we call the trusted badge awarders, in short, badgers. So badgers are usually institutional, they're trusted, and they are allowed to provide, and they are given these badges that they can assign. So in summary, we're looking at the more AI that is coming, the more interactions are going to be. And it's not a matter of they might, or a risk of interactions. Interactions are going to happen. These don't have to be unintentional. If we are prepared, we can make those synergistic, make those work for us. But we do need to agree on infrastructure and centralized resources that they can, those sort of AIs or applications can interact with each other in a very considered manner. So we at Evidently are building some infrastructure for this. It's not the entire solution, but we're collaborating with MCBK and its members to really benefit society through this infrastructure. And again, by way of conflict of interest, I'll just want to explain that Evidently is Evidently doesn't make money off the Evidence Hub. Evidently is using that to bring collaboration between our different users, different customers, allow them to collaborate within them, creating a network. But we're opening this up to the community so that anybody else can also form communities of interest and create their objects and advance not just computable, but medical knowledge in general. Oh, one last thing. If you are interested in early access, we are looking for people who want to contribute objects. We're going to launch Evidence Hub by the end of the month. I should say, if those of you have heard me promise that a year ago, we did launch it last year in the beta program. It was a very brutal beta program. We since unlaunched it, rebuilt it almost from scratch, and we are now ready to launch it based on the feedback from the beta program from last year. So if you are interested in early access and you have objects and knowledge to contribute, you'll be getting in that initial period, you'll be getting some extra support. And of course, we will take your feedback and your usage experience and build that into the system. So feel free to reach out to me either through my email or this barcode. Thank you. So now I'd like to open this for discussion. I'll stop sharing. And I'm ready to answer questions.
Okay, thanks, Guy. That was really helpful, very clear and fascinating approach that I think you're taking there. So if you have questions or comments, please feel free to put them into the chat now. To start the conversation, Guy, back to your central point about interactions, do you foresee the capability of your evidence hub being able to kind of traverse across a library of knowledge objects? Does that offer a potential for detecting potential interaction?
That's a good question. I think, this is a new concept. It's somewhat similar, maybe you could say, to GitHub, maybe to Wikipedia or Reddit. We think of it as a combination of all three. But as a single entity, I don't think there's a precedent for this, and so it's very hard for me to answer this question. We really want to get some experience looking into this. I think that detecting interactions itself could be an AI task or some other research area in itself, because we don't even know how they can predict. And just like, again, I'll go back to the analogous that there's no one way or a finite number of ways that drugs can interact. We always get surprised by another way that two drugs interact. I would say the same thing about AI, and maybe even more so, but we've got a lot more opportunities for different AI. There's different classes of AI that do different things, that operate on different kinds of different parts of the health system. And those interactions, like in the example that I gave, might not be direct. So the interaction might be through the health system by one shutting off a particular resource and another one recommending its use. And so those two AI, the detection of the interaction here is really detection a non-event, or what's missing, a lack of interaction, rather than like a negative or harmful interaction. So how to even classify those interactions, how to detect them, this is all very academic, and I think I'd love to see some work in academia, somebody publish about that, and happy to contribute to that if anybody here is interested. But I think this is a very new area that is going to be a big problem unless we start exploring it in time.
Yeah, no, I think that's absolutely right. What about the interaction with commercial AI, commercial knowledge objects? I mean, you showed us the graphic of all the Cerner elements that contain knowledge in some way. And clearly the kind of open source knowledge, if you like, that you're describing is typically from a different kind of community. Do you see any potential for interaction between the sort of, I know it's not open source, but you know what I mean, open community versus the commercial community?
Yeah, that is a very good question. Actually, something we've been pondering around the office, but I can't say that we have a very good solution for. There's a school of thought in the company that thinks that if we, or our interest is for there to be a lot of knowledge on the evidence hub so that it can really make a difference. And for that, some people suggested that if we allow people to monetize their knowledge on the evidence hub, then they will have an incentive to post more knowledge, and we might have a little revenue stream out of that as well. That is a bit problematic because sharing, well, knowledge, in order for it to be shared, it needs to be open. You cannot share a secret. by definition. So it's a little bit difficult to put a knowledge object and expect people to understand it without explaining what it is or how to use it. And once you do that, of course, it needs to be open, at least in the sense that anybody can see what's inside. It might still be licensed, and if you want to license, so far we've decided if you want to license the knowledge that you have, you can license it for commercial use outside. We don't even need to know about it. It's your object and you own the IP. So we think on the platform, we can keep it open. Outside the platform, there's a whole wide world that people can use to interact their knowledge. And quite honestly, I see this as a new paradigm, especially in medicine. There are similar websites in other industries, maybe, but medicine has its own unique nuances. And I think I am very curious to know. I'm actually curious to find out how people actually use this. We intended one way, but as we know, that's probably not what's going to happen. In fact, if there's one way I know people are not going to use it how is intended.
Indeed.
So that's I'm quite curious. I'm looking forward to that.
That's great. Thank you. So we've got a question in the chat from Pablo. I don't know if you can see that guy. I'll just read it out. So Pablo says, I work in psychology and the data we record is less certain or objective than in medicine. What can we do to mitigate for this uncertainty for when data is then being processed by or between AI systems?
Right. So I guess there's a couple of elements to this question, and I want to first address the difference between data and knowledge.
Mm-hmm.
When we talk about the evidence hub, we don't want to see data on it. We actually, even as part of our spam detection, it's not spam, but we are actually checking that there's no patient data. We try at least as much as we can to verify that there's no patient data that's hidden in these objects. So because these objects are open, of course, we don't want them to share data. So we distinguish between the data, which is essentially what we know about people, and the knowledge that is what we know about, in your case, psychology, but it's what we know about the world or medicine. And so there are ways to represent less certain knowledge. And I am not in psychology, so I can't really be specific about this, but I think that there can be, there is psychological knowledge, even if it's less certain. It is still knowledge and it can still be shared on the platform. Now, in terms of AI, actually, I would say that compared to other algorithms, what is unique about AI is its ability to deal with uncertainty. So as an AI, so I've been in the AI industry since 1998, and I've seen all different kinds of what's called AI, that a lot more than what we call AI today, which is large language models or generative AI. There's all kinds of AI, and every single one of them is there to deal with a certain level of or a certain kind of uncertainty. So I think I'm, again, looking forward to actually seeing various applications of AI coming out of psychology. I know that there are already a lot of online psychology self-help sites, and I don't know how good they are. I'm definitely not endorsing them, but I think there's definitely an open door for AI in psychology to actually help with that uncertainty.
Yeah, and just to add to that, I think there's a broader point that medical data actually isn't often as objective or definite as is sometimes perceived to be. There's usually a human element involved somewhere in the process, isn't there? So Fran has a question here. What mechanisms are in place to prevent or reduce misinformation within knowledge objects?
Yeah, that's a very good question. I think we're very cautious about this, and maybe if anything, I think we prefer to err on the side of a little bit too cautious sometimes. And what I mean by that is that every knowledge object has an owner. That owner can assign contributors or members, but those members and owner are do moderate the discussion around their objects. And the instructions we give them is to try, I mentioned a little bit, right? Is even if somebody doesn't agree with you, if it's on topic and it's relevant, it's better that you discuss this openly with them rather than shut them out. But also, if somebody is irrelevant, nobody will know. So if somebody is creating a knowledge object, they are considered an authority on that object. If somebody else wants to create an object or branch that object will get, I mean, this is technical knowledge. We're not talking about conspiracy theories or some controversial, as far as I can see it, at least, or maybe I'm missing something, but I'm happy to be shown something a scenario I'm not thinking about. But definitely, I think that if somebody was to put some sort of, you know, I don't know, knowledge without evidence behind it, for example, that the community will be quick to ignore it. This is unlike, say, Facebook or the more general social media like X. This site is preserved for very specific topic with a lot of specialists. Sorry, and also I'm hoping kind of the third element of this, if you will, is that the badgers will actually create a bias towards the high quality objects as well. So that's why the badgers are not automatically assigned. Anybody can assign a badge, anybody can be a badger, but we're giving them to institutions that are more trustworthy, like you know, publishers or journal editors and or maybe you know, healthcare professionals that can with good reputation. So it's not going to stop, but what we're trying to do is to promote the more high quality knowledge to the top, to make it surface so that the misinformation kind of sinks to the bottom, doesn't get much attention, if not outright removed. I should say that at the moment on the website, there is no report button. We did think about a report button. We haven't implemented this because it looked a bit superfluous with the strong moderation policy that we have. So we could make it better, but we're trying to find the right balance. So I'm very happy to hear if you have scenarios that I'm not thinking of. That'd be great.
Thanks. I mean, on that report thing, I mean, another kind of report is the sort of yellow card incident report. We use this knowledge object and these 10 people got killed. How do we track, you know, is there an option for your system to track that kind of thing, which then brings in the question of liability? How do we manage those issues?
Right. Well, these are quite difficult. I think liability is very jurisdictional. Very jurisdiction dependent, and I think people who use these objects must use that at their own risk. I think I should say, there's actually, you reminded me with the yellow card, is that we can't actually give people a yellow card when in their comments. So if people make comments that get rejected too often, they will get a yellow card, and then they will be locked out of commenting on the system. Sorry, that is a security element we do have. But yeah, in terms of what people do with these objects, you know, if we accept liability on those, then we have to shut down. There is absolutely no way we could accept liability on this kind of content. In terms of the authors, I think quite the same. If you have knowledge and you want to share, it has to be assumed that you're doing this in good faith and not to kill people, and not to cause harm. there is always a manual override, and if something like this happens, we can take things down, or at least put versions on them, or sort of retraction labels, for example. This has not come up in our use cases, so in the beta program, nobody actually thought of that. So congratulations, that was quite a unique thought there. But yeah, I think this is all part of how I think this will evolve. It's a new system, and I'm really looking forward to, like I said, this is fascinating to me, how people can use or misuse a system like this. I'm looking to learn a lot about human nature in this, but I think really we're hoping to keep a community here, a sense of community, and maybe naturally this would not be the place where conspiracy theorists or quacks come to share knowledge. I would hope so, because it's computable. It actually puts quite a big hurdle on entry, so you have to really think it through, and I think that itself might be enough, but I don't know.
Yeah. So a couple of slightly more technical questions about implementation, if I may. So first question is whether this kind of resource might somehow sit behind a CDS service that is accessible through CDS hooks and therefore implementable in an EHR. And then a second question in terms of content types. Does it have to be executable content, or could it be something like the World Health Organization DAC, the Digital Accessibility Kit, which gives a logical model, which is a kind of standards neutral, technology neutral model, but isn't actually directly executable, but does, for example, give you a data model or a process model for various scenarios? So two questions then. What about CDS hooks? What about technology neutral content?
Yeah, so with CDS hooks, it's definitely something we're looking into. We do want to prioritize our activity around this website, and so limited resources and all, but we're waiting for this demand to hit us. It's not hard to add, but we have other features that we're working on that I think will make a bigger difference. For now, early stage. It would be great to get the sort of level of maturity in the knowledge that's on the website that people can start connecting with CDS hooks. That would be great. And we really we want to get there. We just know it's going to take a little while. But I think it's also inevitable. So CDS hooks or smart or both, that's all on the cards and on the roadmap. The second question was, remind me the second question?
Second question was a non-executable content. So, for example, a logical model from WHO DAC.
Right. Yeah. So, yeah, absolutely. I think from our point of view, computable, it means readable by computer, not necessarily executable. We have examples of knowledge like that. For example, value sets. These are just groups of medical concepts that are together to mean something collectively, and they're not executable, but they are reusable. And so for us, a knowledge object is worthwhile sharing if it is reusable. It could be executable, it might not be executable. All of that is captured within the MIME type. So you would define your MIME type to mean executable under what environment. And then using that MIME type, you can have executors that are registered and they can pull those objects. Again, to register as an executor does require review, a bit like an App Store review on Apple, but that's it's free, and we're delighted to do it.
Okay, very good. I'll discuss with you the next stages of the nice work and see whether we might be able to upload something to your library.
That'll be great. Yeah, if anybody has knowledge to share, really, I think my biggest fear is when we do launch this at the end of the month, that people will go, okay, I can't find the knowledge download. I can't really understand what knowledge is here. And so we really would like to have as much knowledge as possible on there.
Okay, so we're at just past 10 to the hour now, so probably last few minutes of opportunity if anyone else would like to raise a question or make a comment on what we've been discussing today. Everyone's a bit shy this time of the morning, I think. Haven't had enough coffee yet. Okay. Well, let's draw it to a close there then. Thank you ever so much, Guy. That was really interesting.